Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners working with older adults be the best they can be. And now your host, Mandy Chamberlain.
Hi everyone. Before we get started, I wanted to talk about Seniors Flourish's sponsor, Great Seminars and Books. What I really like is that their mission is focusing on geriatric rehabilitation education and training for clinicians, which, as you know, is near and dear to my heart. They have great live courses focusing on topics such as clinical orthopedics, cancer rehab, or even topics such as clinical neurology. There is a course for anyone looking for evidence-based practice and treatment ideas while working with the older adult population. These are definitely some topics that I am interested in, and I think you should check them out too. So head on over to seniorrehabproject.com/great and use my promo code SRP25 to get $25 off your next course. Welcome everyone to the Seniors Flourish podcast. I'm your host, Mandy Chamberlain, occupational therapist, and we like to talk about everything occupational therapy and everything in relation to working with older adults. So today the topic is documentation domination. I feel like I should sing it. I don't know. But my guest today is Alexis Joelle. She's an occupational therapist, and she is going to be helping me discuss and kind of dissect CPT codes. We're going to do a case study, going through some goals, daily notes, skilled terms, everything to kind of really get your head around documentation. It's not an easy subject, so I just want to make sure that we are having some really good concrete examples and things that you can take away and use in the clinic tomorrow. So, Alexis, thank you for joining me.
Thank you for having me.
So I just kind of wanted to start out. I like to start out just kind of giving everyone a background of what is your OT journey? How did you get to where you are today?
Yeah, so it's an interesting story. Starting out in community college, an occupational therapist came to speak to our class. It was a programs for special needs class. And she just started talking about meaning and activity and what she does with her clients. And I thought, what is this profession? And how can I get into this as fast as possible? Because she literally explained the definition before I even knew what occupational therapy was. And I still didn't know what occupational therapy was in grad school, like 6 months in.
Yeah, exactly.
It was crazy. And I was like, where can I sign up? She goes, well, you have to get a master's. I was like, done. I am finishing bachelor's and I'm going for it. And I graduated in 2011. Mm-hmm. And after doing some per diem work while I was interviewing some travel companies, I just went straight into travel therapy within Northern California. And I did that for 3 years, and I went through so many various settings, saw so many various diagnoses from acute care, acute rehab, transitional care units, independent living, skilled nursing, working at the VA with active duty soldiers and veterans. And that in itself gave me that broad perspective of what is OT all about and why do we do what we do and why do people do what they do and what's meaningful to them. And then I decided to settle down. I had met somebody. I thought, travel gave me what it needed. I accomplished my goal. And now I work in an acute care hospital setting for the past 2.5 years permanently. And my other passion for the last 1.5 years has been focusing on taking care of my community on a bigger level, including my OT colleagues around me, so we can all do what we need to do in terms of serving our clients and accessing their meaningful occupation. So I've found myself in a place that I never thought I'd find myself before in serving my community online, which is crazy. And
it is crazy, isn't it? It's fun.
It's super fun. And it's been so great to discover people like you and others out there that are doing the same thing. Like, all right, I'm not in this alone. And it's great to see like how we all have our unique piece to bring to our colleagues and to our community. And so here we are.
Yeah. Isn't that the truth? It is amazing the people that you can meet and connect with, just online. And like you said, that's, my goal as well is to help other, occupational therapy practitioners, be the best they can be so they can serve their patients. And that's, we have the same, what's the word I'm looking for? Like, our goal is the same. And so, but we have very different, avenues of doing that. So it's just kind of a neat way to meet and connect with other OTs. So I'm really glad I found you.
Thank you. It's been so great.
So we're talking about documentation. Whew, yeah. Big subject. So, okay, let's just start at the basics. Why are we even talking about documentation? Like, why is this an important thing to even talk about?
Yeah. So in my opinion, we at the heart of OT comes from our heart and our passion for what we do and bringing out that meaningful activity. And we can convey that message while we're interacting with a client. Unfortunately, insurance companies and those that provide the income to support our clients need that evidence in writing. And to convey that message may not be as easy as that human interaction we have with our clients. And so talking about the documentation today is so essential so we can complement what's in our heart and put it on paper and convey a message that is easily translatable by anybody that's not an occupational therapist that just needs to know why you.
Mm-hmm.
So
yeah.
It's a beast, documentation is a beast. And even if we have just some, like you were saying, some tools to work with to get us on the right footing, that practice just becomes a snowball effect and we get better and better and better at conveying that message in writing.
Mm-hmm. Well, and it's ever changing. Like our basic, notes and those types of things are kind of the same, but we have all these different evaluation codes, or we have, all these additions and all these things. And you feel like, of course, that documentation is taking over our practice and it's taking away from what we are meant to do. But like you said, it's so important that, you have to have good documentation in order to provide that service. So it's like, once you get, right. You practice it and it gets easier and you get better at it. And, but specifically at the beginning, it's just like overwhelming and you're trying to, relay what's in your brain, what you've been doing, what is skilled onto a piece of paper. And then it just turns into a monster. So what I want to talk about is the new CPT evaluation codes.
Oh. Yeah. So that's one of the reasons why I put together a worksheet. I just took what AOTA has already provided us. And I do encourage the listeners to go onto the AOT website and get those documents because I believe they are available to those that are not members. Yeah. But they're extensive. The outline is not sexy. It's a lot of information. And in putting together the worksheet that I put together, it's also lengthy, but it's also, you've got to think about it in chunks of a formula, right? You have to plug in each component of what we do as OTs, everything we look at, and plug it into a formula to be able to figure out and come out with an equation, like an answer to your equation. Mm-hmm. And that's really what I came up with when I was looking at all the information out there and figuring out how do I put together what I already have in my headspace for an evaluation and implement it in these new codes. And that's really what it is you're taking formula by formula by formula and adding them, and there you have your answer. So that's the biggest thing is how to plug in each of those pieces. I'm excited to get into the information of breaking down case by case because I think that also helps with understanding what that formula looks like. And
yeah, absolutely. I think well, let's just go through the case study. Let's go through our case study that we kind of talked about, and then we can kind of figure out from the case study, determine which CPT codes you would choose and then why. And then maybe we can explain what each of the levels are. Do you want to go through the case study, Alexis?
Sure. So, interestingly enough, in looking at the patients that I've had, I've found a similar diagnosis with that fits each complexity level. It's different patients, and they each fall under a different complexity eval code based on the complexity of their medical background, the complexity of symptoms, their occupational profile. So let's go into that. So the first case, you have somebody who is a healthy, active person, 66-year-old male who had cervical radiculopathy, and they had to undergo an elective cervical spine surgery. So you find that this individual works 40 hours a week. They're on the iPad, the laptop, the smart device in terms of their work majority of the time. They don't have much medical background. They had a knee replacement, but overall they're very active. They walk, bike, they hike, and they live alone. And so this healthy individual doesn't have very much complexity at all. Just very basic, quick and dry, going in, getting my procedure and coming out. And not very many basic ADLs to address in terms of barriers, but maybe training of how to do grooming hygiene while waiting out the precautions to heal, and some training for laptop use and smartphone use, so they can maintain the integrity of their neck, not only when they're healing, but afterwards. And so you find yourself not having to provide very much treatment, so minimal treatment information or education, still important. And the person is healthy minded and physically sound. So you find yourself with more of a low complexity, because even though we have someone who we can still help, their case is very simple. And I think that's a big thing to take away from that is the simpler the case is and the aha moments that just come, that gut feeling that comes to you right away, it's likely that they are low complexity. The ones that make you think, there's a lot going on, or what can I do for this person? They're really limited. They're likely to be a higher complexity. So I'm just curious, how would you like me to talk about the goals? Do you want me to compare goals after the cut cases? Or
Yeah, let's compare goals, because then you can kind of see the differences in goals really easy.
After the fact, or?
Yeah.
Okay, great. So now we have another case who's 72-year-old female, and she also comes in for a cervical spine surgery for a similar issue, but she has complications of paresthesias in her upper extremities, minimal to no sensation in her dominant arm. And some of the medical complexities and comorbidities that have come up for this individual is not as easy as our healthy, active guy, but she does have some underlying diagnoses that may or may not affect her treatment or affect her recovery. And I apologize because I don't remember too much right now, but I do remember I had a couple things that came up, and I thought I'll keep them in the back of my head. So she also lived alone, and she really enjoyed knitting. One of her biggest things was knitting and cooking. So she definitely was engaging in her leisure and her IADLs. And so that expanded her occupational profile a little bit more in terms of what she does on a daily basis that's meaningful to her. And in terms of engaging in just the basics, that the grooming, the hygiene supplies, manipulating her shirt with her hand, it was more difficult for her. So she actually already had bumped bumped up to a moderate complexity because she had more deficits going on that were impacting her ability to manipulate her supplies. And that already put her down into further brackets of more basic ADLs being impacted. So now instead of having just few, she had several. And it also impacted it on more of a global scale in terms of her leisure and her cooking. And so that was something that we had to talk about even on the acute level, because how is she going to modify her technique while recovering? And also, what exercises did she need in order to hopefully regain that sensation back? How can she engage with her cooking and feel safe? How could she take a bath and feel safe? So we had to look at sensation on top of actual biomechanical changes of how to do things with her C-spine precautions, but also consider sensation, consider the emotional coping with not being able to access her cooking or knitting, things that were very meaningful to her. So we've already hit 3 dynamics in our framework that are also in those codes that show our value. So I put her at a moderate complexity. And one of the things that helped me was counting in my head how many barriers there were, so to speak.
Yep, exactly.
And it's so helpful. It's so helpful. So, and she had chronic pain too.
There's always something else. And, I think you really touched base on, like really using an occupational profile, let it be a paper occupational profile, which the AOTA actually has a new one out, and I'll link to that in the show notes. But like using the occupation profile, I mean, it's not just the diagnoses. I mean, you have to look at the whole holistic person, and you can use that as, like you said, going through and counting all the barriers. I mean,
right.
It's just bigger than just, it's not cut and dry, I guess.
It isn't. And you hit the nail on the head, Mandy, is that the more our secret to our success is investigating what our clients do every day when they wake up in the morning and when they go to bed at night. And those activities are going to be our gateway in understanding how we can help them best, especially in deciding what they need in our services. And these codes are so valuable for that. Mm-hmm. I feel like I've nerded out on it because normally I despise documentation, but when I read these codes and I understood it and I absorbed it like a sponge, I was like, oh, all right, this is finally what we needed as OTs.
Well, and it is our job to be a bit nosy. And sometimes I actually even tell them that. I'm like, it's my job to be nosy. Just getting a good understanding of what's going on in your day to day so I can really make sure that I'm, picking goals and things like that are client centered. But it's it's one of those kind of ongoing jokes. I'm like, that's my job to be nosy, but it is our job to be nosy. Like we need to make sure that we are getting a clear picture of what's going on so we can pick the right evaluation codes, pick the right, goals that we're working towards with our patients and that they're client centered. So anyway, yeah.
Right. And you're right. Those goals have to be client centered. Sometimes when they're more complex and we have to think about it, we get to give ourselves credit for it being more complex. Mm-hmm. Which is so cool. So for the third case, 55-year-old female, younger, surprisingly, but I put her at a high complexity code because she was a traumatic cervical fracture and also had paresthesias in her upper extremities, but also had a concussion and very mild. You think you see this woman and she's very sound-minded, but her kids are walking in the room of her hospital room, and you can tell she's agitated or overwhelmed. You can tell it's just sensory overload is going on, and the stimulation that's coming at her that she normally can handle. I mean, independent with community and kid care, care, where you can toggle all of that sensory information. And so that on top of itself was the first comorbidity, so to speak, because the comorbidities come even just right before you see this patient. They don't have to be past history. Comorbidities can be the patient is here for this the cervical spine repair in terms of their fracture, and then they had a concussion as well. That could be their comorbidity. So someone who, first of all, has to toggle all of that first before they can even get started in understanding how to modify their movements for cervical spine precautions, and to open up their kids, their kids' juice boxes and things like that is already frustrating. And to throw it across the room, I mean, it's already going to be a mess. So this woman as a whole person and what she is and who she is and her roles have completely made her into more of a high complexity evaluation, because there's more to delve into. And there's so many different components that OT brings that we have to assess. And that may not be in that one setting. So that gives us the wiggle room to be able to assess the sensory, the biomechanical, neuro, the family dynamic, the coping, everything. And so there's several things that are happening. So again, we're going back to measure it. The first low complexity, we had minimal things that were affected. The moderate, there was more, and in the high, it's almost all of them.
Yeah. Every area of their life is being affected.
Exactly.
Yeah. And you know what, really, I have found, specifically working in skilled nursing, I mean, I think people get, they get fixated on the low complexity is 30 minutes of, face-to-face time. They have all these minutes associated, which is not necessarily the case. But, I think most of my patients are high complexity. They have, so much going on, not only medically, but, family dynamics and emotionally and cognition. And it's also it's really proving and showing, that we are really dealing with, high need patients, and that it takes a skilled OT, to help them. And so, it's just those CPT codes, there's just like you were saying, it's just so important in making sure that we are counting per se, counting how many areas are we really, really, truly addressing.
Right.
Yeah.
And it's interesting because when I think of, and you can totally correct me if I'm wrong, it's been a while since I've been in skilled nursing. I remember it very vividly in my travel. But in my mind, when I think of skilled nursing facility or I think of acute rehab, I think of high complexity being the majority.
Yeah,
and,
absolutely.
I mean, they need more skilled treatment, and they're there for a reason. And so they are likely there with a high complexity. And I also think about that with long-term acute cares where, those that are not familiar with long-term acute care out there, because I know that there are a few that are in that setting. And I was also in that setting as well on my travel. There are a lot of patients that are dependent and not really responsive, or they're really low, Rancho Los Amigos levels. And those are very high complex cases because you have to assess everything.
Everything.
And even
exactly.
that they're dependent, you had to go through the steps to make sure there wasn't even a fraction of something there. And there's still family, and there's still caregiver burden, and there's just so much.
Yeah.
So it's something,
absolutely.
It's definitely something to think about and reflect about. And I agree with you. I think we got in such a habit or routine of thinking minutes and time, especially with productivity standards and demands. But now we get to really focus on value and the amount and work overload. We can almost consider it I don't want to say a pat on the back, but something is our framework, our rewiring of our brains for knowing that we can now account for value. And the time that's addressed with each of these codes is just a guideline. And it's not set in stone. There's always extra theract we can add. So for example, my low level complexity cases, a lot of the time I find myself adding theract for anywhere from 15 to 45 minutes on top of the low complexity because I still have to educate them. And that might be our only session. We may be discharging after 75 minutes of care.
Right.
And that doesn't indicate that they don't need us. It just means that their case is not as complex.
Mm-hmm. Yeah, it's almost like I kind of view it as exactly, you hit it right, the nail on the head. It's like not necessarily that low complexity doesn't mean that they don't really need OT.
Right.
It just means that their case specifically is not as complex as someone else's.
Right.
Yeah. So it's just a different kind of way to look at it. And, it does get kind of tricky because, I know a lot of facilities, they were like, oh, now we have to do these CPT codes, and the education wasn't provided to give people a good understanding of what they are. And then, like you said, they're using the time, the 30 minutes as low complexity or whatever. And they're just using that. But it's, like I said, it's a guideline. And almost sometimes I'm like, oh, gosh, just throw the numbers out and focus on the client needs and what are we looking at holistically? And then that's actually much easier to determine.
Right.
Levels.
And one of the things,
I don't know.
I supervise the OTs at the hospital of our department. And one of the things I really emphasize with them, because they're constantly asking this, like, well, what about the time? What about the time? And I go, well, how long did you sit? Oh, and I should totally include this for you guys on the listeners. How long did you sit at the computer to look up their profile? And how long did you call their caregiver or call their family member and talk to them? How long did you get the interview with your patient one-on-one? All of that information is part of your evaluation. And we were able to tag on 15 minutes for documentation. But now it's really encompassing in value. And this is not to get confused with just Therac. Let's say you go in for your daily treatment, you're in with the patient at 10:45 to 11. That still counts as just Therac. But when it comes to the evaluation, you have to gather information and you have to absorb it and you have to assess it and you have to sit with it and let your clinical judgment rise up from that. And so I think I hate to say this, but I think a lot of OTs give them less credit than they're worth. Yep,
I agree. Yeah. It really justifies and shows our distinct value. And you're using your activity analysis skills, you're looking at the history, and every setting is different. I'm just going to kind of clarify, like in skilled nursing as an example, we don't get to charge for documentation time. So these are the things that are really kind of tricky and different in different settings. But yeah, you are trying to gather the information and do the interviews with the patients, and it's just like, it's all encompassing. And I think I kind of view it as CPT codes are basically just justifying what we do, why we do it, and that we are of value. And so in the long run, I'm hoping that we will just prove that what we do is valuable, it's beneficial to the patients, and that, a lot of our patients are high complexity.
Right.
And, there's just a lot going on. So it's great. It's crazy. So what do you think, so we went through those three different examples of CPT: low, medium, high complexity. Mm-hmm. So we established their, which category they were in. So we got those codes. So how about some examples for goal setting?
Yeah. So to compare the goals for the low complexity we talked about, a lot of it was focused on new education. So, pardon me, the patient already crossed their legs to be able to put on their pants and their socks. They really didn't need much guidance. They just needed to supervise and assess, in the sense, see how they do it. And they ran with it when it came to the education handout of what they need to do for post cervical spine protocol. But to problem solve a little bit more about how to set up their laptop and their iPad and their smart device, just a couple of education techniques. So in terms of a goal, patient will demo recall of at least 3 strategies with using modern technology devices. Patient will recite 100% of cervical spine precautions and the third one, I think I said, modified independent with accessibility to IADL supplies. in the home.
Mm-hmm.
So
yeah,
we've already jumped. I mean, and this is an acute care level. We've already jumped to how does this look in the real world, because it's really not that complex in terms of basic ADL.
Right.
And so that
basic education, making sure that they're doing what they need to do and following the precautions during ADL performance.
Right. Exactly.
Yeah.
So for our moderate,
low complexity. Yeah. That was low complexity. Okay. Yeah. Moderate.
Low complexity. Okay. So moderate complexity. So this had to be downgraded a lot more, just to get to the basics. So for this individual, she couldn't do her grooming. She'd been thinking about, how am I going to do? So we had to downgrade those goals significantly in comparison. And grooming and hygiene, being able to, one of the goals, I did put a sensation goal in terms of patient will demo visual regard for, the temperature while washing her hands independently.
Mm-hmm.
And another one was patient will demo contact guard assist with manipulating grooming supplies with oral hygiene. And
good goals.
yeah. So I mean, and so you have to think about it a little bit more, right? How and they are a little bit. It's interesting because when the more complex they are, the more basic the goal is.
Yep, absolutely. And
then I believe I put another one in there in terms of C-spine precautions, just the patient's ability to recall the cervical spine precautions.
Right. Always the precaution goal.
Always safety, right?
Yeah, safety first.
Yeah.
Okay. So what do you think about your high complexity example?
Yeah. So I want to step back a little bit from the goals to give a little bit of background before putting goals in. I think in terms of the daily or the evaluation summary or the assessment part, I think beefing that up to reflect the goals is going to be significant in terms of high complexity. So based on patient's extensive occupational profile review and patient's prior level of function being an independent mother, patient benefits from occupational therapy for sensory integration retraining to support her ability to adhere to cervical spine precautions. And so that really gives you this huge narrative of who is this person? Why are we seeing them? What's impacting their ability to do what they need to do every day? And how are we addressing the doctor's request for OT?
Yeah.
And so that you have to go back and think to yourself, how do I provide this translation and conceptualization of who this is, so I can justify a sensory integration goal or the ability to engage with her environment and training the other people around her to be able to do what she needs to do to adhere by her precautions.
Mm-hmm. Exactly.
So that's some of the things that I had thought about before even writing the goals was really justifying that summary and then taking that summary to my advantage to put together those goals of the patient being able to implement her own rest breaks or to eliminate distractions in her environment and time breaks. And the same with when she did her ADL activity, that it was in a quiet environment. And also coping mechanisms to give herself the opportunity to rest and know that it's okay if you can't get through, like putting together your, taking apart that juice box that you want to take apart for your kiddo. And so a lot of it was coping strategies before we can even get to the nitty gritty of, okay, how are we going to put your shirt on and how are we going to, play with your kids without picking them up and things like that.
Yeah. It's like looking at the foundation and, how Yeah, because I think sometimes we kind of jump to, like you said, like a basic ADL dressing goal or something like that. But then there's all these other things that impact that maybe we should be addressing first. Let it be, rest breaks and that kind of thing. A common thing for me in my environment is, like anxiety. Like people get really anxious, which is probably common in lots of settings, but that's a very common thing. It's like, they're so anxious they can't even perform the basic ADL. So let's back that up, like you were suggesting, and addressing some of those things first before we even start going into the basics, which we feel, but it's like you need the pre-basics before we get to the basics.
Okay. It's so interesting, and I'm going to talk a quick story of a patient that I had recently, actually a couple weeks ago, and this poor person had come in. This was actually the second hospitalization they had in I think a few days, because the other hospital had discharged them quickly. She kept on conveying the same message over and over and over again about how she didn't use the word anxious, but she was anxious about the pain. She was anxious about what was going to come. She was anxious about everything. And that itself was a barrier to her ability to get out of bed, to roll,
absolutely,
to get to the commode. And for the first 30 minutes, we, in our interview and our evaluation, was just hearing her in her perspective of how is she going to do everything she needs to do. And nobody was listening to that and talk about the value of OT at that very moment. And one of the things that made me cry was I asked her, I said, before you were discharged from the other hospital, did you have an occupational therapist talk to you? And she goes, no. And it broke my heart because no one was there to advocate for her ability to access the things that that were meaningful to her. And just for someone to hear her concerns about how she's going to do things, just completely broke those barriers down for her, and she was able to get up to the commode. And
it's those things,
Yeah. So it's pretty amazing to be able to step back sometimes and lean back in your chair during your evaluation and just look at this person and say, okay, what do they need right now? Yeah. So in all that,
it's like, take a deep breath. Exactly. But it's so true. Like, it's just like, I kind of always use the, phrase, like, listen to understand, not listen to reply. And I think that applies in so many different settings. And if we can just listen to our patients, then we can get you build such a good rapport, but also it really opens up and lets you be, quote, nosy, like I was saying, and get a big holistic view of your patient and really be able to be client centered, and you were talking about goals and that kind of thing. And the things that are hard for people, that we need to, as therapists, OT practitioners, when we're working towards goals, stepping back and just it's not just about sometimes the dressing that we're working on. It's what are all those other components? Use those activity analysis skills and, talk to and listen to your patients. And also, there's all these, especially with all the coding and all the documentation, they're really pushing, of course, for objective measures. Well, it can be a bear. It can be a pain in the butt, but also you can use those. If you can do a good evaluation and use those objective measures and listen to your patients, your goals come quite easily, which sounds, if you can do the work on the front end, your goals, you're not struggling as much to develop some of those goals because you've evaluated X, Y, and Z. And you're like, that's what they're having deficits in. And that is what I can write a goal for. And so I think really making sure that we're doing a really thorough, evaluation or assessing the, treatment session that we're doing or whatever, but then it presents itself on what we need to be doing next. And I think, like you're saying, listening to our patients, if we can do that, it just, all those things become more clear. And I really, actually, honestly, truly feel that documentation gets easier when we are paying attention, if that makes any sense at all.
Right.
In using our skills to assess the situation. And then everything else kind of falls into place. It's when we don't do that in the front end and then we're struggling to make a goal. But if we would have interviewed or listened better or, used evaluation tools or done all that's right there for you.
Right.
So I guess it's just something to kind of keep in mind.
Yeah. And I was just, oh yes, go ahead.
No, I was just saying it just makes it actually easier, even though it feels like it shouldn't be, but it actually does.
Totally. I agree. And as I was listening to you, I was just thinking about a couple of tips that, I'd love the listeners to take notes on, because there's simple things that we can do to get those answers. And one of the sharpest tools in our OT toolbox is just asking questions. Yeah. And those questions can come from our framework. And that's what's the beauty of these codes, is it gives us the access to use our framework to its advantage. And we actually, we printed out a copy of our framework the same day that these codes were implemented, and we use it all the time. It's readily available for everyone to flip through, because we are OTs and we are dynamic, and it can be abstract, and there's a lot of information we have to assess, but just flipping through it just triggers your OT brain and like, oh, I can ask about this too. Yeah. And the more questions we ask, the more answers we receive, and the better we can develop those goals, like you're saying. Mm-hmm. And one of the things that I always answer every time I write a note is this question: for the purpose of participation in what? Because when an insurance company reads that note, they can't just assume ADL or IDL or self-feeding or functional transfer or laptop use. We have to specify our purpose every single time we write a note. And if we're able to say, for the purpose of participation in self-feeding, or in order to access basic ADLs, that self is that skilled value that we address every day, that just has to be on paper. And that's like a simple thing we can do every single time, just writing it, having it as your template.
Yeah. And using sometimes those key phrases, and everybody kind of has their own style, and you have like you said, your own, skilled little verbiage that people use. But I'm going to attach a skilled terminology quick reference guide. So you have some key phrases, for billing and reimbursement, and making sure we're using terms that are skilled. So I'll attach that in the notes too. So we are going to be giving them so much information and quick guides. It's great. I think it's helpful, because I know it's an area that a lot of people really struggle in. So, okay. So we went through the CPT codes. Is that right? Yeah. Went through the CPT codes. We figured out which is which. We talked about kind of setting up some goals and how to set up some goals. Okay. And so then, what are some other things that you do for daily documentation to make sure it's skilled? Like you were saying, using those key phrases in order to participate in self-feeding or dressing, or so what other things do you think are really helpful for like daily documentation to make sure that we're justifying what we're doing, why we're doing it, and that it's skilled? Yeah.
So in addition to using some of the descriptors that are in the worksheet or in the information provided by AOTA, it's also in Justification documentation handout that I'll provide to you guys, is objective measure. And ask yourself, is what I'm assessing measurable? And that is huge, because if we can show something in accounting framework or something we can measure, we can show progress from daily note to daily note. And I take this example, this is perfect for our case studies too, for those with paresthesias, and it doesn't have to be limited to strength or general dexterity, but the Moberg dexterity pickup test. You're counting how fast they are in putting these pieces into the cup. And then the next, you assess it in a week, or you assess it in a day or two. Then really show measure of progress noted with patients patient demoing increase speed in, manipulation of objects in hand, and how does that apply to ADLs? Always justifying how that applies. And so using that measure to your advantage, and constantly thinking about what can I do that I can count, and what can I do that I can put a percentage on, and how do I assess that?
I know. And it's one of those things like I was saying before, it's like, sometimes you feel like, oh my gosh, it's one more thing to add, but we need to justify, and we need to show that it's skilled. And especially those patients that make those tiny little bit of progress that you're like, I don't know how I can document to show that they can move their finger X more degrees. Right. Like, it's really hard. But if you have an objective measure that might be able to pick it up, to show, so you can justify it to continue skilled services, because it's like, sometimes there's things that we absolutely see and we're like, oh my gosh, they're making progress. But then some of the objective measures are not sensitive enough. Right. So I love the idea, like you were saying, making sure that we are, picking the right, objective measure that will show those gains.
Yeah. And another thing that comes up with my our colleagues that I've worked with is, I don't know how or what's out there. And one of the things I just do, honestly, guys, is Google. I Google fatigue survey or fatigue inventory, and sure enough, something comes up for brief fatigue inventory, and you are able to have something that a patient can do a self-assessment on, and then you just reevaluate it the next week. Mm-hmm. The Borg exertion scale for patients with energy conservation needs, they can, again, self-evaluate pre, during, and post activity, and they can evaluate it a week from now. So if that, and I haven't seen your learning lab, but I can imagine the resources that you've been gathering that people have it at their fingertips to be able to, search for something that they've been looking for. And they're like, oh, that's what I can use. And it's like, takes 5 minutes to implement. So,
well, that's exactly right. And that's actually one of the areas of the learning lab. And that's exactly one of the reasons why I did it, because, we don't necessarily always have all this extra time in between patients, or we're done with work. We want to be done with work. We want something easily accessible, a good resource area. You can look down and be like, okay, I need to address ADLs. Okay. Go in the learning lab, find your resources. Okay. Here's one for modified Barthel, or you want to do, the dynamic reach test, or like you said, the Borg exertion, and they're all organized and linked, and you can print them off right there. So yeah, you're exactly right. That's one of the reasons why I started it, because we don't have time. Exactly. We want something that we know is evidence-based and that we can use, and it's gonna be beneficial to us and our patients.
Right.
But gosh, digging around, you can absolutely dig around, and it's out there, like you said, but it's like, finding the time to do it. Yeah. Yeah. But you're exactly right. Those evidence-based, or the objective assessments are such an important component of justifying our skilled service.
Yeah. And that's the thing, is like time, we think, again, we go back to, and I'm reiterating this because I know it's such a habit for us, is we're focused on there's not enough time, or what time do we put on this? And just consider that part of the process, is that you are entitled to think clinically. You're able to clinically reason, and you're able to be given the opportunity to say, this patient has a high complexity. I have to do some digging. Mm-hmm. And I have to find the right assessment.
Find the right assessment. Exactly. So, like you're saying, so daily documentation, making sure that we're showing that it's skilled and that kind of thing. And so I just kind of wanted to reiterate some of the things that Alexis and I have put together for everyone to try to make documentation. Well, so you can dominate documentation. So Alexis, so all these things will be in the show notes, or also if you go to www.seniorsflourish.com/podcast documentation. I'm going to have them listed on the website as well. But we're going to, so Alexis is adding a documentation justification handout. Is that right? Is that the right terminology?
Yeah, there's a CPT
one
worksheet, and as a bonus, I put in the documentation justification handout that has some key phrases, an example of what documentation assessment summary might look like, and some suggestions. And a couple of the suggestions we talked about are on there today. And so that's what's included in that. And then, of course, if anyone has any questions or suggestions, or there's something I completely forgot because I'm human, I'm happy to answer or put that in a revised copy. So the platform allows you guys to stay connected with me so I can update new versions. And actually the version I put out for you guys is 2.0. So I have revised it since I put it out in January. So it just keeps evolving and hopefully gets more concise, or it is easier for you guys. I'm definitely open to suggestions, because how I absorb information can be completely different from how you guys do. So,
well, and it's ever evolving, and things you get more ideas and then you can add it. Yeah. And then in addition, I'm going to do, a quick reference, key phrases for billing and reimbursement kind of, PDF. I'm going to add the, AOTA, our framework, just as a quick, reference, since a lot of us, using that, like Alexis, you were saying, is such a good way to kind of trigger some, like, oh yeah, I should be addressing this or addressing that. Sometimes you just need those extra reminders. And then also just making sure, that we have the AOTA occupational profile that they have out. It's just having all those resources at your fingertips. I think makes our jobs easier. And so I want to just make sure I have all those in the resource area. And also, like I said, just go to seniorsflourish.com/podcast documentation. And then Alexis, if anybody has any other, like you said, specific questions, where can they find you in the social media world?
Yeah. The easiest way to get a hold of me is my email, info@alexisjoelle.com. And if you want to stay up to date with me on social media, all of my accounts are the number 8, Alexis Joelle. So Facebook, Twitter, Instagram, and alexisjoelle.com.
Well, thank you so much, Alexis, for it's like an iceberg. You see the tip, and I feel like we maybe just got the tip, but there's so much underneath.
Right.
But, I'm hoping that, you have some practical tips that people can see the examples, hear the examples, kind of talking it out. I think also kind of helps people process that and be like, okay, versus just seeing it on a piece of paper, but then giving all the resources and, dominating the CPT codes and, the tip of the iceberg of documentation. So I really, really appreciate you being here today.
Thank you so much for having me. It's been so fun, even though I'm nerding out because normally it's not sexy, but it's super great to talk about OT and meaning. And so it's been really great.
Oh, thanks, Alexis. And thanks everyone for listening. And I look forward to talking with you next time. Hi guys, don't forget to check out the live courses from my sponsor, Great Seminars and Books. I love the variety of courses they offer, specifically because they are relevant to the populations that we are working with every day, older adults. And their topics include things such as home health, a specialty course of its own, and clinical implications of pharmacology for the therapist working with the older adult. So all these topics are relevant, evidence-based, and very practical. These are treatments that you can learn in the course and take back and use right away. So head on over to seniorrehabproject.com/great and use my promo code SRP25 so you can get $25 off your next live course.
This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.